Welcome back to Echo Diabetes in the time of COVID-19. I want to welcome back faculty member Dave Faldmo, who's Quality Director and Medical Director for Siouxland Community Health Center in Sioux City, Iowa, and runs the Project Echo program in his area. Dave, thanks so much for joining back.
Thank you.
Do you mind sharing with us some tools that you think could be most helpful for PCPs caring for people living with diabetes in the time of COVID?
We've used a lot more CGMs, continuous glucose monitoring, to help us, and we're currently using a CGM where we can remotely monitor where their sugars are, with the patient's permission, and make rapid adjustments every couple of days, which has been really good. And it's really helped with our care. But for those first few months, I think we really stumbled and grappled with how do we really care for these patients, especially those that maybe weren't doing well with their diabetes.
What resources do you recommend primary care providers take advantage for their practice for patients and with diabetes in the time of COVID?
So, I mean, for sure, the diabetes in time of COVID-19 resources online. I still go back to the site to pull off resources here and there, and so that's a great resource. But there's so much online, in addition to the diabetes in the time of COVID-19. I mean, there's lots of other educational programs that are free that people can take advantage of, that providers can take advantage of, but just local community resources too, to help patients with their social determinants of health too. There's so much out there now. I mean, we've had patients have been displaced from their homes, that have needed housing, that we've contacted our community resources to help them find temporary housing. The food insecurity part, we've partnered with our food bank to have actually food boxes on site. As when we had our parking lot clinic, if there's families in need, we're able to, we'd test them for COVID and then give them a box of food to take home with them. And so just partnering with the local resources in the community. There's a lot of, grants out there right now where there are agencies that have money available and resources available to help these families. And, it's always going to be our patients that are metabolically unfit that really are hit the hardest and that might have the biggest need. And so just making sure we're partnering with those community agencies to help our patients from a holistic standpoint.
What have you seen in terms of coverage for continuous glucose monitors, CGM, since COVID, maybe kind of commercial versus your Medicaid, or maybe people who are able to pay out of pocket?
Yeah, so that's been a struggle. And so a lot of the times we'll use our professional CGMs that we just purchase ourselves, and can actually just supply those to the patient if their insurance doesn't cover that. And so that's been helpful. But for those that want a personal CGM, we run into the same problem sometimes. But, again, fortunately, a lot of times they do have coverage that will allow them to have CGMs, but the deductible and everything like that always plays into it. And so I have one patient right now that he's more of a white collar worker, but he's met his deductible for the year, so he's all about the CGMs right now. But he says after the first year, I'm probably not going to use this anymore. But he's all about it right now. So it's been good. But that's the sad part, is that I wish we could just treat everyone the same and that we could get universal coverage for some of these medications and technology, so we could really give optimal care to everybody the same way. That's one thing that we've upped our game a little bit too, is just with social determinants of health and these patients that contract COVID, and maybe they don't have a lot of community resources. They don't have family, they don't have friends that can go to the grocery store. We delivered a lot of food boxes to patients during their isolation or their quarantine time. So I had the opportunity, actually, on a few weekends, I'd just go out myself, and it was really enlightening to me. And again, we wouldn't go into their homes, but we would drop off the box on their front porch or in their apartment building and just kind of talk to them on the phone. But a couple of times I did have to go in to the apartment complex to get to where their room was, and see them open their door and kind of see what's going on. I just remember one patient that's a Somali patient. She's probably in her 50s, but was living in this small apartment with 4 or 5 other individuals just, sharing rent to make ends meet, and they all had COVID, and fortunately they all did fine. But you could just see how the virus could spread because of social determinants of health so easily in these populations where there's multi-generational families living together, or just, a bunch of adults sharing a small apartment. There's no way that they're not all going to get it in those tight living spaces. But because our patients work in these work environments, the meat processing plants and those types of environments, we had a huge outbreak late spring where we just started becoming overrun with patients coming in needing testing, and they were sick. And you could just tell those that were metabolically unfit just how sick they were getting from COVID, where others would do well. And so we learned a lot, and we were the main place where the community came for testing. And so we developed a drive-through testing site where we could test them outside, not bringing them in the clinic. At the site where I see patients, we turned our parking lot into a clinic basically, and had a workflow developed in just a matter of days where we could run through 100 patients and do the testing. And we saw mainly patients who were established patients, but we saw many patients that did not have a primary care provider and maybe didn't know that they had diabetes, and from coming in for testing and maybe finding out that they had COVID and needing some follow-up visits, we were able to establish care with a lot of these patients and help start treating some of these chronic conditions that they were unaware of. So it's been quite the adventure. In the New York Times just yesterday, there was an article that talked about the different communities and how they're impacted, and they called out our area, the Sioux City area, for the community that had suffered the longest. I can't remember exactly how they worded that, but just how that we've been hit and it really hasn't gone down much, and now it's going up, and that we've just per capita over the time of the pandemic, we've had more patients infected with COVID-19 than per capita than any other area except for maybe one.
Well, and what are you hearing about patients who might not come in emergently, but maybe who you follow for diabetes or metabolic issues, and having to work for financial need and not having an option not to go to work? Like, what are you hearing in terms of patients?
Yeah, so it's been interesting. So a lot of patients are really worried about working and contracting COVID when they have these underlying conditions. And so some of them have applied for short-term disability, and we do all we can to assist them in filling out their paperwork. And if they're truly at risk, we're certainly supportive of helping them get that paid time off through their short-term disability. It was interesting that one of the meat processing plants in our community actually told employees that had diabetes that they didn't have to come to work for a few months even. And then after a few months, they told those employees they no longer could just continue to pay them, but they would have to apply for the short-term disability, and many of them did. And this particular company actually has a very active program for employee health for patients that have diabetes. And they do a little bit extra for them. They get some extra benefits to help them with their monitoring supplies and things like that. And they ask us to give them feedback to their employee health nurse on how the patients are doing with their A1Cs and their different measures that we monitor throughout the year. And so that company was very proactive in trying to help those patients that were at risk, perhaps just stay off work until it settled down. And they couldn't do it forever. And so that's when they they had to apply for short-term disability. Where most of the companies, didn't do that. It's kind of up to the employee to apply for short-term disability to be off. But most patients, after a while, though, even those that had short-term disability would eventually know, I know I just got to go back. And by that time, most of the employers had put precautions in place with social distancing and screening and to make it a bit more safe. But that first few weeks that things kind of blew up here, I mean, there were just hundreds of patients coming in from these meat processing plants infected with the virus. So it was a scary time for many of them.
And do you want to talk a little bit more in terms of how PCPs might be able to take advantage of this time to help patients manage their blood sugar and maybe try new medications or new regimens?
Sure. Yeah, so I think one advantage of not being quite so busy, having less patients willing to come in, we've had more time with each patient for each visit, and it can really look over their medication regimen and how they're doing and their diet, and talk to them a lot more about that. So I've personally found myself looking to some of the newer agents, the SGLT2s and the GLP1s, and using those in the appropriate situation where maybe otherwise I would have just been tinkering with their insulin to try to get better control. So that's been good for me, and it's been good for the patient too, to really look for opportunities to use the appropriate medication based on their risk profile and other comorbidities that they might have. And so I feel like as a provider, I feel more proficient in when to utilize some of these newer agents.
Is there anything else you'd like to share with other providers, maybe unique to your community, or kind of learnings from this pandemic with patients with diabetes?
Yeah, I think just the mental aspect of the pandemic, at least in our community and in our clinic, just burnout from the staff and provider team aspect, but also the patients. Everyone's just really tired of COVID-19 and want to go away. But it's easy to get complacent, I think, at times, and kind of put our guard down. I think that's why we're still struggling nationwide. We really have not been vigilant in just really adhering to the guidelines of masking and social distancing, and so just looking at the mental health part of our patients. I mean, we have patients that are really scared and really afraid. They know that they're at risk for complications if they were to contract COVID, but so just being there for them from a mental standpoint, and make sure we're looking at their mental health and seeing what support we can give them, or what evaluations need to be done to make sure that they're getting adequate mental health as well as their physical health.